morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audience in different parts of the world. Welcome back to yet another edition of very informative educational lectures for you. The speaker for the first session of today's webinar is our honored guest and senior faculty from India, Professor Manas Panigrahi. Professor Manas is a professor and the head of Department of Neurosurgery at the KIMS Hospital, Hyderabad, India. He's an important member of the Neurological Society of India as well as the Asian Congress of Neurological Surgeons. His clinical interests are focused upon surgery of skull-based tumors, cerebrovascular diseases, neuroendoscopy, and spine disorder. He is a noted author with several publications in various peer-reviewed journals. He's a very active proponent and part of academic events held for young neurosurgeons of various organizations. We are extremely honored to have him today as our speaker at our webinar, and he'll be talking about surgery of intraventricular tumor. The speaker for the second session of today is our honored guest from China, Professor Hong Bo. Professor Bo is a professor and director, Department of Neurovascular Intervention, Clinical Center of Neuroscience, Shanghai General Hospital, Shanghai Chia Tong University Medical School, China. We are extremely thankful to his acceptance of our invitation to be our speaker at our webinar. And today he'll be talking about endovascular treatment of wide neck aneurysm. The chair for the first session today is our distinguished and honorable senior faculty from Japan, Professor Masamichi Kurosaki. Professor Kurosaki is a professor, Division of Neurosurgery, Department of Brain and Neurosciences, Tottori University Faculty of Medicine, Tottori, Japan. He's an important member of the Japan Neurosurgical Society and Japan Skull-Based Surgery Society. He's a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Manas. The second chair for the second session of today is our honored guest from Japan, Professor Yoichi Morofuji. Professor Morofuji is the chief neurosurgeon in the Department of Neurosurgery at the National Nagasaki's Medical Center, Japan. His research interests are focused upon endovascular neurosurgery. He's a noted author with several publications in peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Hong Bo. On behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. A warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. And with that introduction, I would hand over the online podium to our first chair, Professor Masamichi Kurosaki. Professor, please.
Thank you. Thank you very much for your kind introduction, Dr. Professor Liu. And thank you very much for joining us this session. It's truly an honor to chair this session. My name is Kurosaki, and I'm the chairman and professor of Tottori University. Tottori is the western part of the Japan, Honshu Island, a very small town. And my specialty is the skull-based surgery and especially endoscopic and nasal transsphenoidal surgery. Today, I have a special guest from Dr. Manas Kumar Panigrahi. Let me briefly introduce Professor Panigrahi. He worked as professor of neurosurgeon at NISAM's Institute of Medical Sciences and has over 20 years of experience as a neurosurgeon. He is a specialist neurosurgeon, and he has done many surgeries. For example, more than 500 CP angle tumors and more than 400 aneurysms. One of his specialties is the endoscopic surgery, of course, the pituitary surgery. And today's his topics is surgery for intraventricular tumors. Please, Professor, please start your lecture.
Thank you, Professor Kurosaki, for the introduction. I'd like to thank Professor Yokokato, Dr. Raja, and Dr. Boon Singh for organizing and inviting me to participate in this forum. Today, I've decided the topic is on intraventricular tumors. What I'll be talking, because intraventricular tumors is a vast topic, so I thought I'll confine my presentation for today to third ventricular tumors and how we practice in our hospital. As we know, lateral ventricular tumors is a big topic because it has tumors of the frontal horn, body, atrium, temporal, and occiput. And third ventricular tumors are divided into anterior third ventricular and posterior third ventricular. So today I'll speak only on the third ventricular tumors, and maybe if I get an opportunity sometime later, I'll speak on the lateral ventricular tumors. In the past 10 years, we had 186 cases of intraventricular tumors involving the lateral and the third ventricle, and almost half of them were males and half of the females. I'll take case examples from the cases we have operated in the past few years. Almost 2/3 of them are adults, like more than 18 years of age, and 1/3 were children or less than 18 years of age, because we practice both adult and pediatrics in our hospital. Among the 186 patients, as you can see here, lateral ventricular tumors formed almost 25%, or like 25 to 30%. The anterior third ventricular is almost 97 cases, almost half of them, and posterior third ventricular was again 25 to 30%. What I'll be discussing today is about anterior and the posterior third ventricular tumors. The commonest anterior third ventricular tumor is colloid cyst, which I will not be discussing, as colloid cyst is a different lecture by itself, discussing about microscopic versus endoscopic. I have taken only the anterior third ventricular tumors like gliomas or optochiasmatic gliomas, the ones which needed surgery, like this, huge ones, and posterior third ventricular region tumors like pineal region tumors. For anterior third ventricular tumors, or especially both for intraventricular optochiasmatic gliomas or craniopharyngiomas or glioma, what we realized is when we see cases like this, most of the time we get confused what approach one has to do, whether one has to do a terminal approach for this or a interhemispheric approach for this, and many times, especially in chiasmatic glioma, we have following surgery, they have had deterioration of vision when we approach through terminal or interhemispheric, depending on just the extent of tumor. But then we started doing DTI of the chiasm and the optic tract in all these third ventricular tumors to decide whether to do a terminal or whether to do an interhemispheric approach. Like this patient had the chiasmatic fibers displaced superiorly. So it became easier for us to make a decision that one has to do a terminal approach rather than an interhemispheric transcallosal approach. Then in this case, if one does an interhemispheric transcallosal, there is a higher chance of visual worsening, as terminal is safer. And this was the patient operated, and this is the scan done 3 months post-op, almost total excision, and this is the patient who came for follow-up. Compared to this case, is again a thalamus lesion in the third ventricle, hypertense lesion with hyperintensity in the thalamus and the hypothalamic region. And again, we had deciding whether to do a transcallosal or terminal, as you can see here, so just on the third ventricle. But when you did a chiasmatic DTI, here one can see that the fibers were displaced inferiorly. So we approached the tumor from transcallosal interhemispheric approach from the above. And this turned out to be some granuloma. Again, a similar case where this was operated in 2015 before we were practicing doing DTI, and we had done an interhemispheric approach fortunately, this patient, the reason was same as pre-op, but then we had decided the interhemispheric depending on the extent and because this patient had hydrocephalus, not an objectively deciding which is the best approach. So we compared with the cases, like 8 cases which we had operated of the third ventricle when which we did not do a DTI. And yeah, as you can see here, all this we were done before 2015, that many of the cases had worsening of vision. So we had done almost 60-70% TVML and only 3 cases in transcallosal, but some of them, at least 4 of them had worsening of the vision. After 2015 onwards, we started doing DTI for all the cases, and of the 6 cases operated, we did a TRNL or interhemispheric depending on the shift of the chiasmatic fibers. And one can see here post-operatively, we did not have any deterioration, and 3 of them had improved, and the other 3 remained in the same state. So there was no worsening. So when we compared both the groups, the patients whom we did not do DTI before 2015 and before, and with DTI 2015 and after, one can see here that when we did DTI, there was no worsening, and when without DTI, there was 4 patients who had worsened. That is one reason where when we were not sure, that's why if you look at literature, people offer only radiation or chemotherapy in chiasmatic glioma because we did not have an idea how to approach the tumor. So doing a DTI helped us to decide how to reduce the morbidity of vision and excise the tumor. Having told how we do anterior third ventricular tumors, let me tell a few lines on how we treat the posterior third ventricular tumors like this or the pineal region tumors. As this is meant for young neurosurgeons and residents, I'll tell a little bit of history on anatomy of the pineal gland also, or in the posterior third ventricular tumor. So people knew the function of pineal gland in 300 before Christ, but till 1910, nobody had touched pineal gland. The first attempt of resecting was done only 110 years ago. And this had gradually, progressively over a period of time, different approaches were pioneered by Professor Dandy into 1991. Then we had transcortical transventricular approach when Professor Weinberger in 1930. Until after 30 years, Poppin came with occipital transtentorial, and in only 1970, the Stein approach came, which is infratentorial supracerebellar, which is very popular now. Now, to understand this approach, a bit of anatomy, so the pineal region is bounded anteriorly by the third ventricle, superiorly by the splenium and the tila choroida, and inferiorly by the quadrigeminal plate and midbrain tectum, and posteriorly by the cerebellar vermis. So this region is like pineal region tumors or posterior third ventricular tumor is a complex region which needs a lot of planning before doing a surgery. Of all the tumors which form in the posterior third ventricle, they can be grouped under 4 categories. The commonest is germ cell tumor. The second common is the pineal parenchymal tumors. The third is the glial tumors, and 4th is miscellaneous tumors. 70% of them are germ cell tumors, and only 15 to 30% are pineal parenchymal tumors. So understanding germ cell tumor is very important as it is the commonest, and not all germ cell tumors need surgery. So when do we operate a pineal tumor or a germ cell tumor? As in the previous slide, as you can see here, that 60% of the tumors are germ cell tumor, and only 14 to 20% are pineal parenchymal tumors. and rest all are astrocytomas or meningiomas, ependymomas, hemangiomas, or arachnoid cysts. I will be taking example of only the commonest tumors like a germinoma or non-germinomatous tumors. Among the germ cell tumors, again, 70% of them are germinoma and 30% are non-germinomatous tumor. And among these non-germinomatous tumor, again, if divide, half of them are teratomas, half of them are yolk sac tumors or embryonal cell tumors. Now, it is one has to decide a treatment, one has to know the prognosis to be how aggressive. It's a benign tumor, one has to be aggressive in removing or treating it aggressively. But if it's a highly malignant tumor, one has to do a logistic thinking of how aggressive one has to be tumor. That is why it's important preoperatively to know how to suspect that it is a malignant or a relatively benign tumor. As germinomas, they form 70% of the germ cell tumor. They have a good prognosis. One has to be aggressive in tumor. Similarly, in pineocytoma and similarly in mature teratomas. Whereas non-germinomatous tumor, if you suspect preoperatively non-germinomatous, and it's a very huge tumor, then one has to be very cautious in subjecting them for aggressive surgery or aggressive treatment. So it's important to have a good knowledge of radiology and preoperative signs and symptoms and the age group to suspect what are we dealing with, whether you're dealing with a germinoma or a non-germinoma or a pineocytoma or a pinealoblastoma. The pinealoblastoma are again aggressive tumors. Again, the type of approach depends on there is associated hydrocephalus is there or not. You can have a posterior third ventricular tumor without hydrocephalus, or you can have tumors with hydrocephalus. And hydrocephalus again can be only involving both lateral ventricle or involving third ventricle. If the third ventricle is dilated, it's easy. One can do an endoscopic biopsy as well as third ventriculostomy. But if the third ventricle is full of tumor, then one has to one cannot do ETV, so one has to do a shunt. So this type, depending on the presence of hydrocephalus, the choice of treatment differs. And again, depending on the age, if it's an infant, the commonest pineal tumor will be pinealoblastoma. So in infant, if it's a large pineal posterior third ventricular tumor, patient is not doing well, failure to thrive is there. One has to be really counsel the patient properly before going for aggressive surgery or chemotherapy. But in childhood, most of the time is germinoma, and so in a childhood, one has to be very aggressive in treating the tumor. In young adults, again, they are non-germinomatous, again, they are bad. So you can see here alternately, infants and young adults have a bad prognosis, but childhood and older adults. Older adults have more common pineocytoma. In childhood has germinoma. They have a better prognosis. That's like a bimodal presentation. So if you have an infant and young adult, be cautious. There is a childhood and older adult. One has to be very aggressive as they have a more low-grade lesions. This is a summary of the imaging finding of different tumors. As you can see here, that one can differentiate the type of tumor depending on the type of calcification, whether it's a rim type of calcification or whether there is an intrinsic spicules like a calcification or a large calcification like pineal parenchymal tumors will have large blocks of calcification, where germ cell tumors will have small spicules of calcification. So presence of the identifying the type of calcification, whether it's a big blocks or small, one can predict it's a pineal parenchymal or a germ cell tumor. This is a very important differentiating point. And whereas gliomas do not have calcification. So radiology is as important in planning treatment for germ cell tumor compared to any other site. So as I told you, if the patient has hydrocephalus, one can do an extraventricular drain, shunt, or third ventriculostomy, depending on the need, which I will be explaining in the consecutive slide. Then for tissue diagnosis, one can do a biopsy with third ventriculostomy or a stereotaxy biopsy or an open surgery. This decision again depends on the age of the patient and the radiology, MRI and CT scan finding and the presentation of the patient. And for tumor control, followed by biopsy, one has to do radiotherapy or surgery or combine this radiotherapy and surgery or combined with chemotherapy or stereotactic radiosurgery depending on the size of tumor. So principles of management can, to decide the principle of management, one can divide the posterior third ventricular tumor into 3 groups. Group 1 tumors without hydrocephalus, like this case, artery lesion involving posterior third ventricle, pineal region, and the ambient system, there is no hydrocephalus. There is tumors who come with only biventricular dilatation and tumors with triventricular, like both ventricle and third ventricle also is dilated. So the options of surgery are endoscopic option becomes more important when triventricular dilatation is there. Like these are the cases which are operated in the past few years. This is the case which I had shown. And this is one infant came with a large tumor in the first third ventricle without any hydrocephalus. And this is another case came with multiple lesions. There is an adult, no, it is childhood, 11-year child who came with a lesion in the posterior third ventricle and a lesion in the enhancement in the pituitary stalk and pituitary also. So multiple lesions. So how do we approach these lesions without hydrocephalus? Do you have to offer surgery, biopsy, or something else? So all these cases who come without hydrocephalus, we suggest them as there in the literature to do tumor markers, either CSF or serum, both serum and CSF. And wherever CSF is possible, as I showed you the cases, in at least 60-70% of the cases, we can do a CSF. And if it's not possible, one has to do a serum. And most important is to do alpha-fetoprotein, beta-HCG, and alkaline phosphatase. If beta-HCG is very high, then it is most likely a germinoma tumor. But if alpha-fetoprotein is high, it's most likely non-germinomatous tumor like teratoma or embryonal carcinoma. So this helps us, just doing a tumor markers gives us a pointer to what is the diagnosis, and then we can suggest treatment with either chemo or radiation directly without going for surgery. So CSF levels tend to be more sensitive than serum levels. As I told you in the previous slide, alpha-fetoprotein is a hallmark of endodermal sinus tumor, of fetal yolk sac tumors. Beta-HCG is for trophoblastic tumors like germinoma and choriocarcinomas. And it not only helps at the diagnosis, but it also helps in monitoring response. After treatment, one does a serial serum serum levels of alpha-fetoprotein and beta-HCG. One can detect early recurrence and also can predict whether there is response is good or not. Like this case, which I had shown, this was an 18-year-old female with there was a tumor in the pineal region and there was suprasellar, where the beta-HCG was very high in the CSF, and then biopsy was not done. Patient was given directly radiotherapy, and this is the this is post-radiation. Patient has been on follow-up for the past 4 years. This is the case which is showed. Again, the beta-HCG was high, only radiation, no biopsy, and this is the response following radiation. Now, this is the infant which I showed with the pre-treatment. The CA level was very high. It was suspected as non-germinomatous tumor, and then because this was a child, he was subjected only for chemotherapy, and then you can see here there is a significant reduction in the size of the tumor with just 6 cycles of chemotherapy. So of all the cases we had done, what we found was with 3 tumor markers, we had a good sensitivity of 92%, though it was not specific very high, it was 73% specific, but it was sensitive in 92%. In many cases, we could avoid surgery by just doing a tumor marker. So having told about this group 1 tumors, let me take examples of tumors with triventricular dilatation and biventricular dilatation. The choice of approach can be a third ventriculostomy because it's an added advantage of doing a biopsy. When only the lateral ventricle is dilated, again, the decision to do an external ventricular drain or a shunt depends on what we suspect. If you suspect a benign lesion which can be excised totally in a third ventricular tumor with just only lateral ventricle dilated, then temporary EVD is okay. But if you're suspecting a highly malignant tumor, which you think that after excision or when you cannot excise totally, and after excision you expect that it will recur fast, it's better to do a shunt because otherwise patient will come back for a shunt later after surgery. So, so if you suspect radiologically and depending on the age profile, there is a malignant tumor, we do a shunt, or if you suspect a low grade, we do a temporary extraventricular drain and go for excision of the tumor. There is tumors like this with triventricular dilatation is the posterior third ventricle with third ventricle dilated. Here, all of us will agree that we'll do a third ventriculostomy with a biopsy. But to do a biopsy and third ventriculostomy together, one can use a rigid endoscope or one can do a flexible endoscope. People who use flexible endoscope, they do with one burr hole, both third ventriculostomy and biopsy. But we have been practicing with a rigid endoscope where we plan 2 burr holes depending on the sagittal MR. A line is drawn from the top of the dorsum celli through the foramen humerus projected on the skull, and then another line drawn from the tumor through foramen monro and projected on the skull, and we plan the burr hole by calculating the distance from the masion here. So we practice 2 burr hole technique. As published in this literature, that if one uses a flexible one can do it with 1 burr hole, but we practice 2 burr hole technique to do a third ventriculostomy first, followed by a biopsy with the anterior burr hole. So as I explained, we plan the calculate the site of burr hole on the sag MR, make a C-shaped incision, make the 2 burr holes, and first use the posterior burr hole for third ventriculostomy, then use the anterior burr hole for the biopsy of the tumor in the posterior third ventricle. Like this case, with dilatation of the third ventricle and the tumor in the posterior third ventricle. This is the video. Do a third ventriculostomy. You can see here both mammillary bodies, the basilar artery, the third ventriculostomy is done in front of the basilar artery behind the infundibular hypophysis. Once you puncture, lift the floor of the third ventricle into the cavity of the third ventricle so that one does not dilate. This dilatation is not done in the prepontine space because dilating that might cause bleeding from the perforator. So always dilate in the third ventricle, and then use the anterior burr hole. This is the aqueduct is the interthalamic adhesion, and then this is the tumor bulging in the posterior third ventricle. And biopsy is done taking biopsy forceps. But using it with the forceps takes multiple bites, and every time you need to take out the biopsy instruments, you get very minute tissue. So to get the number of to increase the volume of tissue of the tumor and to avoid multiple passes by placing the biopsy forceps, we started using this infant feeding tube, number 4 infant feeding tube, where we cut the tip of the infant feeding tube, which has multiple holes, and use the infant feeding tube to obtain biopsy. Like this case, which is a 42-year-old male, came with headache and vomiting for 1 week. This patient was operated earlier for a right frontal glioma, and a cerebellar lesion that was reported as grade 3 astrocytoma, and she had come after 2 years with a hydrocephalus with a lesion in the posterior third ventricle. So again, we did the third ventriculostomy as well as biopsy of the posterior third ventricle. This is the video. Here we use a laser to do the third ventriculostomy. That was an older case when we did not have laser. This is a thick membrane because it was difficult to puncture, so you use laser. So this is laser coagulation of the floor, and then with the Fogarty catheter, the floor was enlarged. And once the third ventriculostomy was done, we use the anterior burr and see here the tumor is seen in the posterior third ventricle. This is the interthalamic adhesion. You can see here the tumor. So here, instead of using the biopsy forceps, we use the infant feeding tube and aspirate. The infant feeding tube is placed on the tumor and aspiration is done. The infant feeding tube is rotated clockwise, anti-clockwise, as you can see in the video, so that it does like a suction and cutting. You can see here the tissue entering the infant feeding tube. So with this technique, one can get a very good yield amount of tumor tissue, and one need not do multiple passes. So it's like a QSA, like a Poorman QSA. And finally, hemostasis is done by placing the Fogarty catheter. Either laser or the Fogarty catheter can be used like a mechanical pressure to achieve hemostasis as shown in the video. You can see here, the Fogarty catheter usually is kept dilated and kept compressed for 1 to 2 minutes to achieve hemostasis. And hemostasis is achieved. It's important that hemostasis is achieved. One has to stop the irrigation and see that there is no bleeding, and one has to check that the blood pressure also is normal before the endoscope is removed from the ventricles. So this is another case of a 3-year-old with normal tumor markers. So we had to do a biopsy, do the third ventriculostomy with biopsy, and this is after surgery with only chemotherapy. There is resolution of the tumor. This is a patient again with the normal tumor markers. Following biopsy, we had to give radiation, and this is the scan after radiation. So what do you do? This is for the third group, like tumors which do not have third ventricular dilatation, then doing an endoscopic biopsy becomes a problem. In this group, as I explained earlier, whether the decision to do an external ventricular drain or shunt is depending on the age of the patient and the suspected pathology from the radiology. If it's a benign, you do an external ventricular drain and go for excision of tumor. If it's a malignant, do a shunt and go for excision of tumor. But they have some tumors like this, huge tumors in the posterior third ventricular region, where you suspect a low-grade tumor and you do not, it doesn't look like germinoma, where that you can treat without surgery. So here one has to go for excision of tumor. Or like this tumor, without hydrocephalus, again large tumor, intensely enhancing, suspected low-grade tumor in the pineal region. And again, this was a low-grade tumor in the pineal region. This is again low-grade tumor without hydrocephalus. So all these cases, which is suspect radiologically and age-wise low-grade, one has to go for excision by a craniotomy. Now there are many approaches described for doing the excision. Posterior supratentorial, you have interhemispheric, you have occipital transtentorial, you have Stein's approach, infratentorial supracerebellar, and you have infratentorial paramedian supracerebellar approach. Now, or you have a combined approach, supra and infratentorial, described by Professor Sekhar and Professor Goel. Now, how to decide which approach is best for the particular patient? To decide that, one needs to see again the radiology properly. It depends on the location of the tumor in relation to the tentorial incisura, whether it is below the incisura or above, or it is both. And see the lateral extent of the tumor, displacement of the great vein of Galen superiorly or inferiorly, and what is the probable diagnosis imaging, and the angle of the tent. A steep angle again is difficult for a supracerebellar approach and surgeon's preference. We prefer to do a combined approach in most of the cases, though Stein approach is very common, but we prefer to do a combined approach. We decide the type of approach depending on the tent, angle of the tent, and the extent of tumor. Draw a tangent to the upper pole of the tumor and another tangent from the lower pole of tumor, and decide the extent of craniotomy depending on the tangent to the upper and the lower pole of the tumor. As a running short of time, I'll not go through the details of the approach, but these are the common approaches. Basic thing one has to understand is, if the tumor is small, less than 3 centimeters, and it's in the midline, Stein's approach, midline infratentorial supracerebellar, is fine. But if it's extending laterally, one has to do a lateral paramedian approach if it's a small tumor. But if it's a large tumor with lateral extension, an occipital transtentorial or a combined supra-infratentorial is better. So the decision to decide the approach depends on the size and the extent. The more the lateral extent, the better. Then occipital transtentorial or a combined is better, or a lateral paramedian if it's a small one. But if it's a midline small, a Stein's approach is better. This is how you position the patient. So to do a combined supra-infratentorial approach, the advantage. Will not go to all these details of advantage because I've been given 40 minutes, and so this is how we position the patient. And this is what we had published in long ago, that for doing the combined approach, one can do a midline incision or a S-shaped incision, so that one can do with a smaller exposure, do the combined approach, both supra and infratentorial exposure. So here either S-shaped or a hockey stick of incision in as a single flap, both supratentorial occipital craniotomy and suboccipital craniotomy is done. This is what we practice to avoid complications. We let out CSF from the cisterna magna so the cerebellum falls up, as we do not do in sitting posture, and place gel foam between the tent and the cerebellum to prevent cerebellar damage while cutting the tent. So here, after letting out CSF, the gel foam is placed below the tent, and then we open the dura supratentorially. This is the occipital lobe being retracted up, taking care of the veins draining into the tent, and the tent is cut parallel to the superior sagittal sinus from posterior to anterior. It's not anterior to posterior because we don't retract till we identify the common technique described is identify the free margin and come back. But as we have already placed gel foam below, so we go from posterior to anterior till the free margin of the tent and cut the whole tent parallel to the straight sinus. Once that is done, the tumor is identified in the pineal region and excised. And this is at the end of tumor excision. We do this for all types of pineal tumors to have a better visualize from the anatomy, and it's easier to achieve hemostasis with a larger exposure. And this is how it looks after surgery. And this is how it looks, the post-op scan looks after at the end of 3 months. This is again as only a small ring along the quadrigeminal plate was left out. This again after surgery, this turned out to be pleomorphic xanthoastrocytoma. As I explained you, when you suspect low-grade tumor, you go for excision. We could not excise totally because this part was adherent to the vein of Gland. This is a tectal glioma, again excised totally with no residual tumor. This is scan done after 3 years follow-up. This is another patient in the posterior third ventricular, and we suspected a low-grade tumor. Excised is the post-op scan with no residual. Transcallosal interhemispheric is not very popular because the chances of disconnection in posterior disconnection, you have chances of visual anomia, hemialexia, auditory anomia. So Dandy's approach is not very popular, so we usually avoid do a callosal disconnection in posterior third ventricular tumors. Transventricular, it's a tumor extending into the atrium and occipital horn. Then this approach is preferable. It is a very large tumor because just doing from the interhemisphere, doing from the midline approach, one cannot reach into the ventricle. So it's only for large tumors. Otherwise, it's not required. This table summarizes the different approaches. As I told earlier, that the advantage of midline approach is one, the orientation is good because of the gravity. Because done at sitting posture, gravity assisted retraction of the cerebellum. One can see the veins, but the disadvantage is air embolism. Is a narrow corridor, and if it bleeds, then it's difficult to achieve hemostasis. And sometimes you have to sacrifice vein can cause infarction. One can do this only in less than 3 centimeter tumors. And if it's more laterally situated, one has to do a paramedial for vaginal, but it's again when it's less than 3 centimeter. But if it's more than 3 centimeter, it's better to choose one of the occipital transtentorial or combined supra and infratentorial. That's what I showed the pictures. So at the end of doing all this surgery, what is the outcome for the patient? You can see here, if it's a germinoma, 90% of them can survive more than 5 years using irradiation alone. So you don't need surgery, you just need tumor markers of a CSF and serum, and you can diagnose it. 90% of the cases have a 5-year survival, and you can avoid surgery. And as germinoma are the commonest tumor, 70% of them. So if you look at posterior third ventricular tumor, the need of surgery can be reduced if we properly read the MRI and the age of the patient. And if it's teratoma or immature teratoma, 70% of them again live more than 5 years. And if it's non-germinous tumor, only 67% live more than 5 years. If it's choriocarcinoma or endodermal sinus tumors, only 10%. So these are the tumors that don't do well, and pineal blastomas also don't do well. This is just for recording. This is the summary of all the features of all the commonest tumors like germinoma, teratoma, pineal blastoma, and meningioma. This is for residents or fellows who want to have a summary of the whole lecture of the radiological feature and the prognosis of the different treatment. So the recommended treatment for any suspected pineal tumor depends on the presence of hydrocephalus or absence of hydrocephalus. If there is no hydrocephalus, one can do serum and CSF markers and decide the need of biopsy or not. If it's positive, there is no need of biopsy, one can straight away go for radiation or chemotherapy. If it's negative, one needs to go for tissue diagnosis by open surgery. But if there is hydrocephalus, then it becomes easier to do. If it's again markers are negative, then one needs a biopsy. If it's positive, one again doesn't need biopsy. One has to treat the hydrocephalus either with the third ventriculostomy. So in many of the posterior third ventricular tumors, one can treat without surgery if planned properly. Thank you for your attention.
Thank you very much for a nice presentation, Professor Panigrafi. Do you have any question or comment from the audience? Okay, I have one question.
Yes.
Thank you very much for a nice presentation. In your presentation, you summarize the treatment options or surgical approaches to interventricular tumor or pineal tumors clearly. My question is regarding large cystic craniopharyngioma in the third ventricle. How do you treat recently for the interventricular, third ventricular large cystic craniopharyngiomas?
Yeah, large cystic, in cystic craniopharyngiomas also we do DTI of the optic tract, optic chiasm, and of all the cases done, most of them have the chiasm displaced inferiorly. So we have done endoscope transcallosal as we prefer doing an excision. We do a transcallosal interhemispheric approach and excise the tumor. And if they come for recurrence, then again we do an endoscopic, put a reservoir, Ommaya reservoir into the cavity, and we have done multiple aspirations. We have not used the bleomycin as given in literature.
Really? You use the bleomycin?
We have not used. We have not done. We do multiple aspiration and radiation if there is a recurrence.
Maybe recently, especially for the elderly patients,
yes.
only the cyst puncture through the endoscopic surgery and then radial surgery was popular, I think. How do you feel about it?
Yeah, no, means, but still the cystic ones after radiosurgery also they come back with recurrence.
Yeah.
Yeah, I'm sure you must have the experience of recurrence. So in those cases, we have put a Ommaya reservoir and have done multiple aspirations.
Okay.
But people have described using interferon and bleomycin intracystic. I do not have experience on that.
No, yeah. Neither I. Some question, any question or comment?
Can I ask one question, Professor?
Yes,
please do.
Yeah, Professor, I just want to find out from you regarding the requirement or the need to do a biopsy.
Yes.
In my practice, we usually do biopsy when we suspect it's likely to be a pure germinoma. Like Professor had mentioned, it can be treated just by a radiation therapy without any resection. So may I know from perspective from Professor, what are those cases that absolutely you need a biopsy, and what are the cases that we would not do biopsy, you go straight for resection, Professor? Thank
you. If the scans which I showed you, if you suspect germinoma without hydrocephalus, then we do a CSF and serum tumor markers. And if they are positive, we do not suggest them to go for surgery. But if there is hydrocephalus, then we have to treat the hydrocephalus. So during hydrocephalus treatment, we take a biopsy. So it's only patients whom the decision of biopsy is decided depending on the presence of hydrocephalus. In absence of hydrocephalus, we depend on the tumor markers only.
Professor, would you face problem with radiation oncology without tissue biopsy? In my country, the radiation oncologists, they want tissue biopsy. They don't think that the tumor markers are good. What's your opinion regarding this?
Initially, when we start, I'm sure Professor Kurasi will tell you, but initially when we started telling our radiation oncologists to give, they were very hesitant to give. They were not accepting. But then there were some patients who refused surgery and were forced to give radiation. And now, after seeing the results, now they do not refuse.
Professor Kurosaki? How about Japan?
I'm not sure about Not so. There are in many, not so many institute we have the oncology. So the different, yeah. So it's now time to close. So thank you very much, Professor Panigraphy, and we are looking forward to seeing you soon on site near future.
Definitely. Thank you.
Thank you.
Thank you.
Thank you, Professor Manas, for very nice and informative lecture, and thank you for Professor Kurosaki to chair the session. Next, we call upon Professor Murufuji to chair the second lecture. Professor.
Good evening from Japan. I'm Yoichi Murufuji from Nagasaki, Japan. It's my great honor to chair the session. The second talk today is to be given by Professor Bo Hong from China. Professor will be talking to us about the recent important topic, endovascular treatment of wide neck aneurysm. Professor Bo will present his wide experience of endovascular treatment and his strategy for wide neck aneurysm. Could you start your lecture, Professor Bo?
Thank you, Professor Marufuji. It's thank you so much. And I'm from Shanghai General Hospital, affiliated to Shanghai Jiao Tong University Medical School. And today, my topic is simplify the procedure of endovascular treatment of wide neck aneurysm involving side branch for safety and long-term durability. So I just focused how to simplify this kind of procedure and make the procedure safer and more durable. Sorry. So we all know that for wide neck aneurysm, the major point is how to densely pack aneurysm while preserving the side branch, especially those with function, critical functions. For this slide, I show there are PCOM aneurysm, wide neck, and M1 aneurysm with a frontal branch, SCA aneurysm, wide neck and very small, and MCA aneurysm, the basilar tip involving both of the branch, and also ACOM aneurysm. And it's very common for us to treat such kind of patients. And the critical point is how we can preserve the side branch. For the major branch, of course, we will do whatever you use a balloon or you use a stent or you use a double microcatheter, such kind of technique. But the side branch, sometimes you will keep the patency, but when you do the procedure, especially when you try to select the side branch, it is sometimes very difficult for you. For such kind of this PCOM aneurysm, the aneurysm majorly involve the PCOM, which is a fetal type. So it is a live case in our ocean meeting, and we do transcirculation from the contralateral side through the ACOM and to the ipsilateral ACA, and then go backwards and to the PCOM. And we put a stent in the PCOM, and we do further coiling. Unfortunately, when we do the follow-up, whatever it's a DSA or it's MIA, we found that it regrows. So it is quite, when we do cut a cross section, which is perpendicular to the parent vessel, as lies the line here, and we can see it is this color shows the stent the contour. So it's quite difficult for you to densely packing the space just around the stent. So it's quite difficult for you to have a long-term durability if you do such a kind of procedure. So now we have better stents, for example, the braided stents, and some doctors say it's a barrel technique. In China, we say it's a lantern technique, kind of. Yes, the bulging stent can protect the neck as well as the other side of the branch. Then we can do the packing and keep the patency of the side branch. So from my point of view, stent in the main artery is always a better way, not only for safety, but also for the long-term durability. For such kind of PCOM aneurysm, when we do the stent-assisted coiling or balloon-assisted coiling, so when we use a balloon or stent, part of the balloon or the stent will bulge into the neck and just to make the neck, wide neck become relatively narrow. Then you can pack the aneurysm. The major point is here, you should densely packing the inflow zone, which I showed an arrow here. And then this is the 6 months follow-up. We can see the patency is good for PCOM is good and the aneurysm is cured. So I draw just a illustration here for a common PCOM aneurysm, such as here, when we cut across from the line, dotted line, and there may be different kind of involvement of the PCOM for a relatively healthy or maybe part of the healthy PCOM origin, and then maybe it is more developed aneurysm, almost make the PCOM itself totally involved as part of the aneurysm, but we can still have a framing coil and make a basket, whatever it's relatively normal PCOM, part of the normal PCOM, or even the PCOM is almost totally involved as part of the aneurysm. And when we push coil in the basket, then there will be less chance of the coil loop into the PCOM or part of the aneurysm, as shown here. Then if we use balloon or stent, it make the work much easier for much more dense packing, as well protect the PCOM or the side branch here. The major point, you should densely packing the area I draw as shown in yellow. So even for the such a SCA aneurysm, so when we use a stent, so the wide neck becomes relatively narrow, even we just put a stent as this way. And this is my preferred style for deploying the stent, not maybe as other doctors, they may suggest that we can do a transcirculation from anterior to PCOM to P1 and then put the stent into the SCA. I think the procedure is maybe very complicated and the long-term follow-up maybe not so good. So this is my major point. Just make the procedure safer, and long-term durable. Such as like this kind of case. It's a M1 aneurysm. And from the, if we see from the frontal to the occipital, then maybe we will say, okay, maybe the neck will be protected. If we see from the backward, from the back, oh, maybe we will say, oh, it's very difficult to preserve the side branch. So I draw the contour of the aneurysm, the front, the back, and we can see if we have a good frame, a basket, then we will not sacrifice. So we will not compromise the side branch. And this is 1 year follow-up. Yes, balloon is a very good tool for us. We can see, especially for the higher compliance balloon. The balloon itself, when we inflate, it will bulge into the neck a little bit, and then we can have dense packing, and we will protect the side branch. Even for this MCA bifurcation aneurysm, we just use one balloon. You can see it like this, and we have a very good dense packing of the wide neck bifurcation aneurysm. Balloon is a very good tool. Now we have even more better tool for this kind of small profile stent, which can be deployed through the balloon catheter. So we use the scepter balloon here with the balloon remodeling, and then we do the densely packing of the aneurysm. And because of the balloon, we can protect the small side branch as I draw the red line here. And then after the procedure, I may be not so satisfied with the final results. I can put a stent here, and then with a very good long-term result. This is a good publication by Kono, and in 2013, he drawn and showed us different kinds of stenting technique for bifurcation aneurysms, as a single stent or double stent with non-overlapping or Y kissing or Y crossing, and or even a horizontal type. Also, Dr. Lee, he showed us the drawbacks of the Y stenting, especially for the closed-celled laser cut stent, as like shown here. The red area is not protected by the stent because the second stent was constricted, and the coil itself, when we push coil into the aneurysm and at the neck, the coil may be protrude into the red area. And if you want to have a densely packing of the aneurysm, sometimes it's not so easy. I have such kind of case, using Y stenting. It's my early cases. Can see it's I use a enterprise closed-cell stent, do the Y stenting, and relatively dense packing of the aneurysm, but maybe a little bit loose packing here. But at 1 year follow-up, we can see significant recurrence. And we do further coiling, but another year's follow-up, still recurrent. So I have to give more dense packing, and then I put a braided stent. Fortunately, I can get the catheter through the stent, and I use the balloon to demonstrate, to confirm that the stent is open well. So that's the final result, and the patient is on the follow. I hope she can have a good result. but I'm very worried about this case. So transcirculation horizontal stenting was proposed a long time ago, but from my point of view, for such kind of case, I will not prefer to use such kind of technique, which maybe is not so rational. That this is, I draw a illustration picture here. When we cut across as the green line and then look from other side, can see the stent. But if you want to densely pack in the yellow area, I think it's quite difficult. And it's also not so friendly in hemodynamic. Then the recurrence may happen. If it happens, then it's very difficult for you to treat further. So some doctors proposed one stent, which is, I think it's a much simpler and safer way. You can use balloon to protect, or you use microcatheter or microwire to protect the side branch. Then you can go and for dense packing of the aneurysm, just using one stent. I think it's easier for you, and even it recurred, you can treat the patients with further techniques or procedures. If you use a wide stenting or the horizontal stenting, maybe it's quite difficult for you to further treat. So such as like this case, it's a recurrent aneurysm, ACOM aneurysm, ruptured one. And then when I push the coil to the neck, it will protrude to the other side. And then when I use a microwire, then it's much easier for me to get a dense packing of the neck. So microcatheter or wire protection, sometimes it's very good. For example, for this MCA aneurysm, majorly involve the inferior trunk, which is a relatively wide neck. And I can use a micro wire to protect the frame protrusion. And if you want to get the microcatheter further to the distal, sometimes it's not so easy. And this is the final result. And this is day 2. We do MRA, which shows the total occlusion of the aneurysm. So simple technique sometimes make the big change. Another problem is such a kind of aneurysm, the side branch had a 2 curve, like S-shaped. So if you, yes, this patient is a ruptured aneurysm, and we do the first session just coiling. And 1 month later, we found that the significant recurrence here. So at that time, we tried to do the stenting, put in the side branch, which we use a braided stent, but you can see the stent is not fully open, and I tried to use the microwire to open it, but massage, but it didn't work. And this is second follow-up, showed the recurrence. I have to densely pack the inflow zone on all the neck. And then this is a 5-year follow-up. I think he is quite fortunate, but today I will not do like this. This is not a very good technique. So some physicians suggest the non-overlapping, they call it a T stenting, majorly by Dr. René Chapeau in German. And also Dr. Cho in their proposed the half T, or we say the distal stenting. And Dr. Rennie Chapo sometimes puts the stent, the proximal part, to the other branch. He calls this extended half T, which is amazing technique. And now we have low profile braided stent, and which is reshiftable, and we can do such kind of T stenting. Maybe it's a good technique, but it need technically challenging sometimes. And this is my case. It's which is an ACA aneurysm, and yes, we do use a T stenting technique. This is a braided stent number 1, and this is number 2, and the proximal end of the stent is just at the neck. So we will keep the patient in follow. And sometimes for such kind of case, the pica aneurysm, which is a ruptured one, and we use the distal stenting, or we say the half T stenting technique, such as in this case. But when you put a stent in a small vessel, we should concern that the patency of the small branch, such as like this case is a ruptured pica aneurysm, and we put a braided stent after the coiling. At the end of the procedure, it looks good, but at day 3, the pica occluded, and the patient had a infarction. So maybe we should change our mind for the patency of a small side branch. We can sometimes use the flow remodeling technique, which is like this case, it's a MCA bifurcation aneurysm small branch here, and it's a relatively wide neck and majorly involves a small branch. So we just do the dense packing of the body of the aneurysm and a little bit loose packing of the neck. And we put a stent, which makes the configuration of the parent vessel changed, which I draw the outline here. You can see this significant change. And this is just 1 year follow-up. You can see the aneurysm neck disappeared. It's a very good small branch here. And so that's a different kind of philosophy. And I think it's much easier and maybe better long-term durability. Also, in my other cases, I can show we put a braided stent in the major branch, and we sometimes for these 2 unruptured case, we just loosely pack the aneurysm, and you can see the 6 months follow-up, the cure of the aneurysm, a very good patency of the side branch. So we say this a kind of flow remodeling, and we just need to loosely pack the aneurysm body. So it's with a very good result. So we have no flow diverter. So shall we just put a flow diverter in the major branch, and then the aneurysm will gone and the side branch will keep in patent? I still worried about it. We have not so much cases we put a flow diverter in MCA or basilar because we still worried about this. So this is one of my case, and MCA bifurcation aneurysm maybe can be easily clipped, but the patient he refused to do the open surgery. So I just put a flow diverter here, and this is 1 year and 2 year follow-up. We can see that the side branch, the superior branch, shrink Fortunately, the 2-year follow-up is not worse at the 1-year follow-up. I hope the patient will have a very good result in the future follow-up. So today, I just focus on the patency of side branch. And my theory or my philosophy is most of the side branch can be protected with easy technique. Try not to do so much risky and complicated procedure sometimes, and we can have much more techniques using the double catheter or protection with wire or micro catheter. Balloon remodeling is great, and we can use when we do the bifurcation aneurysm, we have different kind of stenting technique, but for long durability, I think maybe just using a simpler and safer procedure is better. So flow remodeling is we put a stent in the major vessel and we can have the procedure safer and with good long-term follow-up. And thank you.
Thank you very much for your wonderful lecture, Professor Wu. So Professor Wu shared many cases of wide neck aneurysms and taught us how to preserve the especially side branch using balloon or stent or combined. Professor showed his excellent endovascular techniques in detail. Now we are open for the discussion. Any questions and comments from audience or web?
Ben, you want to ask a question, Ben?
Yes, and thank you, Professor Hong, and congratulate to your excellent results on the wide leg aneurysm. So may I ask, in your center, first of all, how do you choose between endovascular treatment or open surgery for the wide leg aneurysm? So how does it work in your center? So the second question is what brand of the stent you usually use in your center? And the third question I would like to ask is in the case of, I saw you have a case of using a stent in acute rupture cases. So what kind of the antiplatelet regime you usually use in those acute rupture cases that you put a stent in?
Okay, you have 3 questions.
Yeah, sorry.
One by one. So in my center, almost 80% of the bifurcation was treated with endovascular therapy, and 20% maybe by open surgery. Then the second question is the stent I used. I used a different kind of stents. For bifurcation aneurysm, I prefer to use a braided stent. And now we have a new from Stryker, the Neuroform Atlas, which is also very good. I think it's a good stent, but before this, I usually choose Elvis or Leo Baby or Elvis Jr. Yes, and also many of my cases by enterprise stent as well in the early period of my procedure. And the third question, during the acute stage of ruptured aneurysm, we do using the GP2B3A during the procedure. And then after the procedure, we will put the patient on dual antiplatelet with loading dose of aspirin 300 and the clopidogrel 300, and we overlay the use of these kind of drugs for more than 6 hours. So if during the procedure we have ruptured complication, we will stop using the tirofibin, which is GP2B3A, and then we will do sometimes open surgery. And then when we closing the dura, which is usually 2 or 3 hours later after the endovascular procedure. So it's good for us because the tirofiban will end the effect. So that's the procedure in my center. Thank you.
Thank you so much.
Can I ask a question?
Yes,
Yes,
Prof.
please.
Yeah. Professor Boone, you said you do everything. 80% of them are done endovascular, whether they are ruptured or unruptured, or ruptured aneurysms also you do endovascular. Because
Yes.
most of the, as you said, most of the time you give double antiplatelets after the surgery. Do you have any?
We do ruptured and unruptured. Yes.
Yeah. Any precautions for giving both clopidogrel and aspirin in the ruptured aneurysms? Have you had any problem in those patients?
You mean because sometimes they need external ventricular drainage or such kind of procedure?
Yeah, one is external ventricular drain, and you have a complication of a rebleed following the procedure within a week.
Oh, so if we have a rupture complication majorly during the endovascular procedure itself.
Yes. During the procedure, or sometimes within 1 week of the procedure.
It's not. It's not so common. Yes.
Because in our experience, we have seen. So how do you decide? Like, how come since your complication rate with the antiplatelets is less?
Oh, which is low. Which is low. I mean, for acutely ruptured aneurysm, we prefer to use just coiling of aneurysm. Using what kind of technique? Double microcatheter balloon remodeling, and we try not to do the stenting at the procedure of when the patient is acutely ruptured.
Thank you.
May I ask a question, Professor?
Yeah.
Yeah, Professor. I have two questions for you, Professor. One, just now you show us that you use flow diverter for NCA bifurcation and aneurysm, and you have shown us that the flow of the superior branch a bit reduced after the flow diverter placement. In those cases, would you consider to do a bypass surgery, or when do you decide when a bypass surgery is needed? My second question, Professor, for wide neck aneurysm, if there is a case that a part of the coil fall into the parent artery, a parent vessel, what are the rescue maneuver can be performed? Thank you, Professor.
Okay, the first question, we have not so much cases experience to do the flow diver in MCA or basilar artery. And from the publication, especially from Turkey, they have a very good results. Although the superior branch or the inferior branch, which was covered, slowed down and shrinked, but usually without symptom. It's symptom free. So usually they will not do any further surgery for the patients. And the second question, I'm sorry, can you say?
For wide neck aneurysm, if that part of the coil fall into the parent vessel.
Okay. I see. No, it's very, very rare for us to have such kind of situation. We can do in our early cases, we can retrieve the coil out using snare or such kind of things. And sometimes we use stenting to keep the coil against the parent vessel. But now we have rare situation like this.
Thank you very much, Professor.
Thank you.
Any other questions, comments?
Yes, Professor Hong, can I also ask any experience in some newer device, for example, using the web and also the pulse wider for those wide-leg aneurysm? Any experience in your center?
We have less experience using web, which is just entered into China recently. And with China, CFDA had a very strict protocol for any new device coming to China. So sometimes it's not lucky for us.
If no further question, I think we can hear a concluding remark from Professor Morofuji. Professor?
Okay. Thank you again for your wonderful lecture, Professor Hongbo. So lately, we can use flow diverters for many types of aneurysms, but I think it's still difficult to cure the aneurysm, which has a side branch from the dome. So Professor Bo shared how to preserve the important branch using balloon remodeling and standing technique. We've learned a lot from your wide experience. Thank you so much. I return the session, Professor Liu.
Thank you, Professor Morofuji, and thank you, Professor Boho, for a very nice presentation. And I think we just on time. We're going to close the session for today. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both speakers of today, Professor Manas and Professor Hongbo, as well as our chair, Professor Kurosaki and Professor Morofuji, for the time and support for the ACNS webinar. I would like also express my sincere gratitude to Professor Zubin for broadcasting this webinar on a WeChat channel. So until we meet again on 23rd of March, this is bye-bye from all of us. Thank you all professors and all the audiences. Thank you, bye-bye.